So my name is Brittany Reed. I'm a speech-language pathologist, and I'm going to talk to you guys about diet considerations and feeding tubes and just kind of the entire swallowing process. Some of this Dr. Cloud introduced and did a great job, so you'll hear it a couple times. So swallowing considerations. So decisions regarding swallowing are challenging. Sometimes this is a very hard conversation for families to have. One, not knowing what to ask, but also because when we get to the point of talking about feeding tubes and changes to your diet, that means the swallowing has progressed, which also means the disease process may have progressed as well. So it certainly should be a shared decision-making process, not something where the patient and family members are trying to make this decision on their own, but certainly involving their doctor, their speech-language pathologist, even their physical therapist, occupational therapist, because we all play a role in being able to help feeding go better than what it could be. So why is swallowing a concern? The basics, hydration. We just heard how important liquid was in terms of the gut. So the body needs water, it needs hydration, especially when you're taking medications and things like that. So being able to get the right amount of liquid intake in and doing it safely. Nutrition, so that's more so like the food we eat, being able to get the nutrients from the food. Quality of life is huge, and that's probably one of the toughest pieces to consider in this whole process. So sometimes there's recommendations that may be made, but there's sacrifices to quality of life. So being able to understand and kind of weigh your options to make that decision. Safety is certainly a concern. So Dr. Cloud talked about aspiration a little bit, but for those of you that don't fully understand what that is, aspiration is when material enters the airway. So when we're talking about swallowing, it could be our saliva, it could be food, it could be drink, it could be medications, all of which are dangerous because when they enter the airway, that means they are headed to the lungs. And food and drink medication should not be on the lungs. It can turn into a pneumonia. So typically when we're talking about aspiration, we all aspirate every day. I probably have choked 3 times today because I talked with food in my mouth, but we have a safety mechanism where we cough or we throat clear. That's our body's way of saying, hey, that doesn't belong there, and your body's trying to clear it out. A lot of times in Parkinson's or in a Parkinsonism, as the disease progresses, it may be silent, meaning that as you eat and as you drink, things may go the wrong way, and there's not a cough reflex or there's not a throat clear. Or maybe sometimes it happens, but not all the time. So that's certainly something we want to take into consideration when we're talking about diet changes, feeding tubes, things like that. And then cognitive status or mental status is certainly going to play a role as well. So, if there are cognitive changes, it may impact your ability to follow complex commands. And if that's the case, that may impact your ability to complete exercises or strategies. So those are all things that have to be considered when talking about diet changes and feeding tube placement. Excuse me. So a lot of times when people come into my office, these are typical things that I hear. There's an increase in saliva. You've heard several times, I'll kind of just drive it home that, the saliva production hasn't increased, but rather the frequency in which you're swallowing has decreased. So there tends to be a lot of saliva pooling in the mouth, drooling if your lips aren't staying together. So sometimes you might see patients with an open mouth posture, or even their lips don't come fully together, may not be that exaggerated, but that in the combination with not swallowing your saliva as frequently results in the drooling, or sometimes even food or liquid coming back out. Sometimes I hear complaints of, oh, you're just chewing, so in one bite you chew for 2 to 3 minutes and you don't actually clear it out of your mouth. That certainly will impact your ability to swallow it if you're just chewing. Lingual pumping, we see that a lot more in kind of traditional Parkinson's, where you're just really trying to get the food out of your mouth and you can't quite get that motion going. The food sticks in your mouth or maybe in your cheeks. Pocketing for sure, so that can be seen at any stage, but where food hangs out in your mouth, maybe even after you've swallowed, there's still some in your cheek or in between your teeth, and you may or may not recognize it, just depending on how far the disease has progressed. And then things that we typically see on like a modified or a swallowing test, is a delayed initiation. So what that would mean is food just kind of hanging out in your mouth or sometimes in your throat, and you actually haven't triggered a swallow. So it looks like it's cleared from your mouth, but if you're actually watching the person, they haven't started the swallowing process. Or sometimes patients will complain, there's something stuck here, like I feel like I swallowed, but everything just kind of hangs out right here. So my job as a speech therapist is to evaluate you. So hopefully you have brought these concerns to your doctor and they refer you to a speech language pathologist. Typically if you're being seen in an outpatient setting or even in acute care, which means you're like hospitalized, a speech language pathologist will do a bedside evaluation. And what occurs during that, it's a lot of questions to find out about your prior level, what you're eating, your day-to-day function, what are your concerns, what do you notice is going on. But it also involves us giving you food and drink. So typically water, somewhere between 3 to 6 ounces, something that's a puree material, so that's typically like applesauce or pudding, and then a solid, which is like a cracker most of the time to see how you're chewing. So we're watching what's happening in the oral phase, so how you're manipulating the food, swallowing it down. We'll also place our hands on your throat to kind of feel how your larynx, and guys, we call it your Adam's apple, is moving, the timing of that, to get a better understanding of what we might expect for a more diagnostic swallowing eval. Typically, there's 2 types of tests we can do as a speech pathologist. One is called the Modified Barium Swallow Study, or better known as an MBS. And there's also a FEES, which is the fiber optic endoscopic evaluation of swallowing. And that's one where there's a little camera, it goes through your nose, and we kind of look down while you swallow. It's uncomfortable, but the test of preferred choice most of the time is the Modified Barium Swallow, because that allows us to see how your muscles are moving as well as where your food and drink are going, and it gives us really good information for being able to plan for exercises or diet changes, or if we need to consider a feeding tube. So typically what happens in that swallowing test, and that's that picture on the left, is that it's done in an outpatient procedure. You don't have to not eat before the test. Most people are worried about that. But you come in, the test itself probably takes about 5 to 10 minutes. We give you different things to eat and drink. They all have barium on it, which kind of tastes like a Tums, and we can watch where your food and drink go. We can also try different swallowing maneuvers and strategies during the study to see if they're going to be successful. So some common things we might try is like a head turn or tucking your chin. Depending on your cognitive status, we might try to have you hold your breath to protect your airway when you're swallowing. There's lots of different things that we can try, but we need to be able to see it on a swallowing test to make sure it's actually working. So treatment. And treatment's going to vary throughout the disease process. But first we want to start with the least restrictive thing we can do, which oftentimes is changing the consistency of a liquid or your food. So if we're talking about changing the consistency of a liquid, sometimes just thickening your liquids a little bit. So we have nectar thick liquid, which is kind of like the consistency of like a V8 juice or a smoothie. Or we can talk about honey thick liquid, which is like the same consistency of a spoonful of honey. But that typically slows the liquid down when you're drinking it and can help you protect your airway a little bit longer. If we're talking about food alterations, we're talking about changing the consistency. So you might have started off on a regular diet, meaning you pick up and eat and drink whatever you want, but maybe your speech pathologist says, hey, it's really hard for you to chew. We notice you're not chewing enough. We want you to chop it up. Or maybe we saw in your swallowing test that when you had things that were solid, even though you chewed it, it all got stuck in your throat and you couldn't quite get it down. So then maybe we would recommend like a puree diet. And a puree diet would be the same consistency again of like applesauce or pudding. So it looks different, but it tastes the same. Most of the time, if something has to be pureed, it means just sticking it in a blender, adding some type of moisture so it's not really dry, and blending it up until it's that puree consistency. We might consider postural changes. So again, that's like tucking your chin, maybe a head turn to the right or left. If you have really bad posture where you're like leaning forward, we might work with your physical therapist to work on adjusting your feeding when you're eating. We can certainly talk about controlling your the size and rate of the food you're getting. So sometimes, just depending, some people are really impulsive and they're just kind of shoving food in their mouth and they can't quite control like the amount that's on the spoon. So we might work with your occupational therapist to order you specific equipment. There's straws. You can't really see it too well in the picture, I apologize, but it basically controls how much you get and the rate you get it. So it's like a teaspoon amount, and then you have to take your lips off the straw, and the little lever has to go all the way back down before you can take the next sip. So sometimes that can be helpful in controlling how quickly someone takes in liquid. And then strategies. So sometimes it's working with caregivers to cue, hey, go slow, use your tongue to like clear things out of your cheek. It's going to look different for each patient, just kind of depending on what they are experiencing. Additionally, as part of treatment is education to know like, hey, this is what I'm seeing, this is what this means. You know, oh, my loved one is coughing. That might not be a bad thing because maybe they can clear it out when they're coughing. It sounds scary, but again, it's a protective mechanism. So just providing a lot of education so you know what you're seeing, kind of what to expect. Again, because this is something that progresses over time. It may be that, hey, this is what you look like now, but when X, Y, and Z happen, this is when you need to come back to see a speech therapist. So maybe you're eating, but you notice you're losing a lot of weight, or your appetite is decreased, or things that you used to love, you're no longer eating, things like that. Education is really important. Swallowing maneuvers and exercises. So that's something just depending on what your swallowing test shows. We might teach you exercises in the office, and certainly depending on your cognitive ability to try and improve your swallow function. That's typically most successful kind of towards the beginning stages of the disease. A lot of research has been done in Parkinson's, not Parkinsonism, but it shows that even in the later stages, exercises don't necessarily improve function, but may improve quality of life because the individual feels like they're doing something to actually help and kind of can help you maintain the level where you are. So this little device in the picture is called an expiratory muscle strength trainer. There's a lot of research in Parkinson's of that being effective, but what it's designed to do is help improve cough function. So if we can put a patient on that, they can complete it at home. It's pretty easy to use. There's a nose clip, and then you put the device in your mouth and you take a hard breath, and it's a one-way pressure valve. And that valve, the resistance can be adjusted over a period of time if needed, but it improves cough function and your ability to clear things out. So if we see on your swallowing test that maybe you do have a sensation to aspiration, but maybe your cough isn't strong enough to get it out, this may be a recommendation, and we can teach you like, okay, after you take 2 bites, you cough, that clears it out, swallow, and that may be something to help improve your swallowing. And then we start talking about, you know, as the disease progresses, PEG placements or feeding tubes. So there's different types of feeding tubes, and I thought this was something that would be helpful to know. So typically a nasogastric tube is the one that goes through your nose, and so that is it's usually recommended for temporary purposes. So a lot of times what we'll see is like a patient goes to acute care, their body's really weak because they have an infection, their swallowing is not safe where it is right now, but they think it's going to get better, so they might offer an NG tube, which is the nasogastric tube, for a period of time. It gets removed before you go home in most cases, and it's not something that's long term, but it is to help you get your hydration and your nutrition, because those are very important. The gastrotomy tube or the PEG tube is the most common, and that goes right into your stomach, and then there's a little tube where you are fed liquids. Medications can also be crushed and put in that as well. And then there is the jejustomy tube, which goes straight into the intestines, but is not as common that is recommended. So there's a lot of considerations for PEGs. A lot of times people come in my office and they're like, do I need a feeding tube? Should I just get one anyway? It's a hard decision, and there's no right or wrong answer, but kind of understanding the pros and cons can help you make that decision. So definitely knowing, like, is this something temporary or is this something long-term? You know, again, if someone's had like a recent injury or a recent sickness, it may be recommended to have a PEG tube. Just because you have a PEG tube doesn't necessarily mean it's going to be, oh, you can only have things through the PEG tube. It might be a combination of both. So sometimes hydration and nutrition is really important, and we say, hey, put mostly everything through the feeding tube, but to this person, eating is still a huge part of their life. You know, it's something social. You go out to eat with your friends and family. You want to be able to do that. So we say, okay, well, you can have this as a snack, kind of like throughout the day, or do this a couple times throughout the day. But to get most of your hydration and nutrition, that needs to go through a feeding tube. The cons. So a lot of times people think that having a feeding tube gets rid of your risk for aspiration, and that's not the case. So you can aspirate from swallowing your saliva, and that can still lead to a pneumonia, or you can aspirate from reflux material that comes back up from things that were put in a feeding tube, and that can still lead to aspiration pneumonia or other pulmonary complications. So it's not necessarily that the feeding tube will stop aspiration pneumonia, but it may be an alternative to get your medications in, which is really important, or an alternative for you to get enough hydration, enough nutrition, things like that. So as patients and caregivers, what should you do? Certainly prepare ahead of time. So, you know, have these conversations. They're tough conversations to have, but have them in the beginning, especially if you are still of ability to make your own medical decisions. Let your family and your loved ones know. Get an advance directive and put it in writing, like, hey, I only want a feeding tube if XYZ happens, or hey, I don't want a feeding tube. You know, even in some cases, people wait till, like, okay, now this person's really bad, but at that point, you know, the body may no longer be absorbing nutrients and things like that, so maybe a feeding tube isn't a great option. But have these conversations even though they are tough. And then knowing that, again, you're not in this by yourself. So ask questions and ask your speech pathologist, ask your doctor, ask them multiple times if you don't understand, or if you want to hear it again, or if you need to involve more family members. The more you know and the better you understand, the better you can make this decision for you or for your loved one. You know, and don't be afraid to ask the really tough questions. It is, like I said, a really hard conversation to have, but being able to understand why a feeding tube is being recommended, or maybe why it's not at this point, can be really helpful. And then be kind to yourself. There's no right or wrong answer to a feeding tube. It's going to look different for each person. And it may change throughout the disease process. And maybe when you first talked about this, you were like, yes, I'm okay with having a feeding tube. It's okay to change your mind later and say, no, that's not what I want. But just making sure that you understand the risks of eating versus not eating, or using a feeding tube and not. That's it.